Welcome. The following presentation is from a satellite symposium presented by Answers in CME, held during the American Society of Clinical Oncology 2026 annual meeting, titled The Promise of Oral Therapy for HER2-Mutant Non-Small Cell Lung Cancer, Unlocking New Treatment Opportunities with a Familiar Target. To access the full program and supporting materials and to claim your certificate, please visit the activity URL in the episode description. This activity is supported by an independent medical educational grant from Boehringer Ingelheim Pharmaceuticals Incorporated.
All right. Well, good evening, everyone. So welcome to tonight's event. It's the promise of oral therapy for HER2-mutant non-small cell, unlocking new treatment opportunities with a familiar target. Brought to you from Answers in CME. And let's see, do I have a clicker?
You should have.
Yeah. Are we sharing one? Let me borrow that from you here. All right. So I'm John Haymack. I'm the chair of Thoracic and Head and Neck Medical Oncology at MD Anderson Cancer Center in Houston. And I'm joined by Mark Awad, who's the chief of the Thoracic Oncology Service at Memorial Sloan Kettering Cancer Center in New York. All right, and here are Dr. Awad's disclosures. And here are my disclosures. Okay, so here are the educational objectives tonight. So upon completing this, participants should be better able to specify how TKIs may address unmet therapeutic needs for HER2-mutant non-small cell, interpret the clinical evidence that will go through for oral TKIs, and assess which patients may be candidates for approved oral TKIs in the context of the current standard of care. The activity is supported by an independent medical educational grant from Boehringer Ingelheim.
Thanks.
And Answers in CME is accredited by the ACCME to provide continuing medical education for physicians. So to earn credit, so this is important if you'd like to get CME credits for this. So in person, you can scan the QR code that I'm going to show in a moment. And if you're streaming after the program, you can click the Get Your Credit button on the type right. And you've got to complete the evaluation form to know about what educational topics will be most helpful in the future. Okay, and here's the QR code if you're here that you need to scan to participate in tonight's event, complete the pretest, and you would need to do this to get credit for the CME as well. Okay, and if you're streaming from home, questions appear directly on the screen, and everyone can ask a question. So these questions will get sent directly to us. Mark and I get them here. We've got iPads here. And if you want to download slides from tonight's event, they're available there as well. Okay, so here I'm going to hand it over to Mark to talk about the state of the science.
Great. Thanks so much, John. It's a pleasure to be here. Thanks to everyone who's joining in person and online. So to kick off our discussion, we're going to talk about HER2 mutations and their role in treatment selection for non-small cell lung cancer, and then we'll review some of the clinical data and practical considerations for treatment selection and toxicity monitoring and management. So we'll first start by discussing the prevalence and the prognosis of patients with HER2 mutant lung cancer. Now when we talk about HER2, it's important to distinguish the types of alterations that we are looking for and measuring, because they are different and they have different implications in treatment selection and as predictive biomarkers of response to different therapies. So this slide shows a summary of the different ways that we can assess for HER2. On the left, you see HER2 protein expression is assessed by immunohistochemistry. So this is a stain that we do on biopsy samples, and we can measure the degree of staining on patient samples. And in lung cancer, we can see a wide variation in HER2 expression levels. The important point to mention here is that there is a solid tumor agnostic indication of trastuzumab deruxtecan for cancers that have very high HER2 expression, which is considered 3+ by immunohistochemistry. We can also talk about HER2 gene amplification, which is typically amplification of the wild type gene, and there's different ways of assessing that by sequencing or historically by using FISH. But what we're really going to focus on today is what we're all the way on the right of the screen is HER2 activating mutations. These are clear drivers in lung cancer. They're mutually exclusive with other driver mutations at diagnosis, and this is a fairly straightforward biomarker. It's more binary, either you have the mutation or you don't, and predicts for a good response to targeted therapies. We know that HER2 mutations are more common in lung adenocarcinoma as compared to squamous cell carcinoma. There may be higher predominance in women and in light or never smokers as well. But we don't necessarily use those clinical characteristics to decide who needs testing. We really aim to test everyone who comes in with non-squamous, non-small cell lung cancer and lung cancer in general. Now, when we talk about HER2 mutations, like with other genes, it's not just one mutation. There's a spectrum of different mutations, but most of the mutations cluster in HER2 exon 20, and we often commonly refer to these as exon 20 insertions. So these are in-frame insertional mutations in exon 20, and you can see them highlighted here in the pie chart on the left. That's the most common type of mutation that we see in exon 20. And on the right, you see a diagram of the different exons across the HER2 gene. The most common being the YVMA insertion at exon 20, but there's a number of other exon 20 insertions, only a fraction of which are shown here. And this is what we call HER2 kinase domain mutations. The exons that you're seeing clustering around exon 20 are representing the kinase domain. But it's also important to mention that there are less common but still important and activating mutations, both in the HER2 transmembrane domain, which you can see here is at present about 10% or fewer of HER2 mutations are in the transmembrane domain. And then there are important extracellular domains. For example, amino acid substitution at S310 can be known to be activating. So we'll talk about some of the nuances and differences in whether you detect a HER2 kinase domain mutation or a HER2 activating mutation outside of the kinase domain as well. So important diagnostically, how do we find these HER2 alterations? So again, there's different ways that we check for HER2 aberrancy. So again, I mentioned on the left is not something we use as commonly anymore, which is fluorescence in situ hybridization, but this in some centers is still used to detect gene amplification. And there are some lung cancers that have HER2 wild type amplification, not so common, but it can be present de novo, or it can be acquired as a resistance mechanism to other targeted therapies. But this is not something that we are frequently detecting at this stage, but just important to mention some NGS reports or other reports do comment on HER2 amplification. In the middle, again, mentioning HER2 high levels of protein expression, which is assessed by a stain. So this is something that can only be done on a biopsy, not on liquid assays. And again, here we do have a approval of trastuzumab deruxtecan for high HER2 expression across different solid tumors. But on the right is what, again, we're really focusing on, which is next generation sequencing, which often is DNA-based, but also could be RNA-based sequencing. And this is the best way we have to detect the various mutations throughout the HER2 gene, both the exon 20 insertions, but also the transmembrane and extracellular domain point mutations. NGS can also be used to determine amplification, which is why it's replacing FISH as a tool here. And again, we really try to emphasize multi-gene, broad panel testing rather than testing for one gene at a time, because the more you do that, you can use up the tissue, and then you don't have really anything left over if you only test for a handful of genes and you've run out of tissue to test. So really, the NCCN guidelines and other international guideline agencies do recommend using broad multi-gene panel testing to look for these HER2 mutations and other actionable mutations in lung cancer. Since there's a growing number of targeted therapies and actionable genes, EGFR, ALK, ROS1, BRAF, MET, RET, HER2 and others, it's really important to make sure that the panels are pretty broad and comprehensive and inclusive of all of these alterations.
Mark, do you want to talk about it, if you go back there? When you get the NGS report, do you want to tell how you can tell if something's a tyrosine kinase domain mutation or exon 20 insertion or transmembrane extracellular? So and this may vary at, at Memorial versus with other big tests.
Yeah, thanks, John. It is tricky because, all of us may use different panels. Some of us use commercial panels, some of us have in-house panels, and then there are differences in the commercial panels in terms of how they report these alterations. There's differences in some of the liquid biopsy testing companies or solid tumor tissue based assays here, and so it is important to really try to study the reports, and some reports are better at raising the actionable important mutations to the sort of top of the reports that are listed as kind of tier 1 alterations. Other times things can be a little bit more buried, so it is important to kind of get familiar with how each person's individual sort of testing platform reports on these alterations. And then often it does indicate where the alteration occurs, either at the amino acid level or the exon area. So often the HER2 insertion mutations are commented on as different nomenclature, but HER2, YVMA, INS, exon 20.
Right.
So it is challenging because there sometimes is a lot of shorthand and notation in these reports. They can be quite complex. But I think the more familiarity that you have with your own
probably
platform.
one point that I've seen catch some people up. So sometimes it'll be listed as the ERBB2 gene.
Right. Yeah.
And EGFR is the ERBB1 gene.
Right.
Anyway, and of course HER3 is also known as the ERBB3 gene, so it's part of that family.
Exactly.
So the naming is unfortunately not
Yes.
Not consistent.
Yeah, and then sometimes they'll show like the cDNA alteration, the protein alteration. So
right.
I think it's tricky, and I think also having good contacts in the molecular pathology group or within commercial companies is very helpful. I often will ask somebody from the company if there's something unusual about the test or something that I'm having a hard time interpreting. So it's always helpful to have a contact through the testing platform.
I think sometimes if they're not well annotated, if you've got a mutation and it's in the 700s, it's probably a TKD mutation. If it's in the 300s, it's probably an extracellular, if you want a rule of thumb for the most part. So
that's great. Thank you, John. And then as we were mentioning also, there's different ways of doing the sequencing. You can test on the biopsy itself with tumor testing. There's also, of course, a lot of liquid biopsies through ctDNA or blood-based assays. There's pros and cons of both methods. Usually tumor testing, of course, it's a more invasive procedure, but that tells you more about the histology, what subtype of lung cancer you're dealing with, if it's adenocarcinoma squamous. But there are risks of doing invasive biopsies. Sometimes you don't get enough tissue, but if you do have a good tissue sample, this can be the most sensitive way of detecting various alterations. Liquid biopsy is fast, it's easy. You see the patient in clinic, you can draw blood immediately thereafter. But not all cancers shed enough DNA or release enough DNA from the tumor sites into the circulation. So a negative liquid biopsy doesn't necessarily mean the cancer doesn't have a targetable mutation. It just might mean that there's not enough DNA for detection. And sometimes the liquid biopsy reports do give you a sense of tumor content, tumor fraction, but you don't necessarily want to rely on that to know if the liquid biopsy is diagnostic or not. So the way I handle this is, if a liquid biopsy report shows an actionable alteration, if it's positive, then I can feel comfortable acting on it. If it's negative, I usually also wait for the tumor tissue resulting test to come back to know for sure if the patient has a targetable alteration. And sometimes you get negative liquid biopsy. You have a small scant tumor sample that maybe is used up for a bunch of IHCs to make the diagnosis. So there are times when I send a patient back for a repeat biopsy, especially if you have a high pretest probability that they might have an actionable alteration, particularly, light never smokers, younger individuals, but that's why genomics is so important in lung cancer. Even older individuals, if safe and feasible, will try to advocate for repeat biopsies if safe and feasible, and if the patient is willing, of course. And then again, very important to test for these alterations, primarily, of course, at initial diagnosis, but also on relapse in the case of early stage disease, or if there's a new lesion or progression on targeted therapy. Again, genomics can be very powerful to know in our lung cancer population, are you dealing with a recurrence of the same tumor, or is this a separate primary, because you don't want to assume that the genomic findings from a few years ago, especially in a heavy smoking population, reflects the genomics of a new lesion, for example. And then if a patient is treated with targeted therapy, you want to retest if safe and feasible with tissue and ctDNA blood-based testing to look for potentially targetable mechanisms of resistance. And on the topic of HER2, we have seen in some cases, after treatment with EGFR inhibitors, sometimes we can see acquired HER2 alterations that there have been small case reports that you can act on them successfully to reinduce a response. So these are important tests to do initially, but to think about redoing along the way when making subsequent treatment decisions.
So are you sending then, you're sending NGS on everybody, this is the tumor in liquid. Are you sending IHC on everybody for HER2?
Yeah, it's a good question. We have a few lung cancer approvals that are based on IHC assays now, which is new for us over the last year or two with HER2, as well as MET testing. We have Teliso-V for MET high expression, and then trastuzumab deruxtecan for high HER2 expression. So again, I think you want to be judicious of not exhausting tissue. So I usually prioritize if tissue appears to be limited, prioritize NGS first and foremost, especially at initial diagnosis. A lot of the IHC assays with a companion drug approval are more so approved in later lines. So, and we also don't know if protein expression levels change over time, like what the expression was at diagnosis may be different when you're then considering later lines of therapy. We can see changes in MET expression, for example, HER2 expression, but often if there's enough tissue, we might do NGS plus HER2 and MET.
So if you have adequate tissue, then send it or wait for the second line?
Yeah, it's a good question. And yeah, if there's enough tissue up front and we don't need the tissue for trials, I usually do NGS, PD-L1 IHC, and then HER2 and MET IHC. I think there's always a question, if a patient gets to later lines of therapy, or if you need to make a change later, will you have the time to do another biopsy? Will it be safe and feasible, or will it be a hard to access lesion? So I don't know if you have a different practice.
Yeah, I think we've just this year, with the approval of trastuzumab deruxtecan for the overexpression, and with the MET ADC, Teliso-V, we send MET IHC as well. But if it's negative with the first line, we'll still sometimes send it in the refractory.
Right.
Yeah.
Yes,
So there as well. Yeah, as you said, it can change. So.
Right. So this is our first interactive polling question. So you can scan the QR code to submit your answer here. So the first question for those here in the room or online is, according to NCCN guidelines, which of the following assays is recommended to identify patients with HER2 tyrosine kinase domain mutations who should be considered for targeted treatments? Next generation sequencing, FISH, immunohistochemistry, or PCR? And we'll give people a minute to
So if you can
answer.
scan to answer, and if you're online, I think an answer, we got over 60 people online right now. Okay.
Great, so the vast majority of people selected NGS, or next generation sequencing, which I agree with. As much as possible, we try to prioritize NGS-based assays, broad panel-based testing, to look not only for HER2 mutations, but other alterations here. And just before we move on to the next section, and I think there's a couple questions that have been coming in from the audience or online as well. how do we tell the difference between a tyrosine kinase domain mutation and a non-TKD mutation? We touched on this a little bit because the NGS reports don't necessarily say this is in the kinase domain or not. So what do you do there?
Yeah. So again, if it doesn't tell you it's a tyrosine kinase domain mutation, first of all, as Mark noted, most the HER2 mutations are exon 20 insertions. So if you look, those are in the 700s, specifically 772, 773 are the numbers. So if you see a number that starts with a 7, it's almost certainly a tyrosine kinase domain mutation. The transmembranes are in the 600, 650 to 659, and then out of the extracellulars, the vast majority are at 310. So if you see 310, it's extracellular. And as we'll talk about when we get to the drugs, that's relevant for which drugs are approved in which settings.
Right.
Yeah.
And then another question, can we describe some of the differences between HER2 overexpression versus HER2 mutation? And that's important too, because sometimes, you might get a pathology report or a genome, and it says HER2 positive or HER2, and you have to kind of delve into the details, like are they talking about a mutation, are they talking about overexpression by IHC? I think NGS reports or mutations in HER2, to me, are a little bit more straightforward. Again, I mentioned it's sort of binary, like either the gene is mutant or not. With HER2 overexpression, it's a gradient, and there is this semi-quantitative scaling, like 1 plus 2 plus 3 plus, which I think pathologists are good at, observer sort of consistency, but there I think it's not as clear of a driver, as clear of a biomarker for treatment selection. I think it is important to not only rely on IHC. So there are some HER2 mutant lung cancers that actually don't have high expression by IHC. So for example, if you get a HER2 stain back and it's low, that doesn't necessarily mean there's not an actionable mutation. So right. So these are kind of important differences between the tests. And
so Mark, do you want to talk about what if it's got both IHC positive and mutant positive then?
Yeah, I think the mutation really, which we'll talk about, I think dominates or sort of trumps, because typically the HER2 mutations are mutually exclusive with other drivers, so especially at initial diagnosis. So if they're HER2 mutant, we never really see an EGFR mutation, ALK, ROS1, et cetera, so the HER2 is the driver. The difference is things like HER2 expression by IHC or MET expression, that can overlap with other gene mutations, other drivers, so it doesn't necessarily mean that cancer is being driven by aberrant HER2 signaling per se, but now these aren't perfect biomarkers for their kind of companion ADC approvals either. So I think that's a challenge for the field of antibody-drug conjugates. A topic for another day is what are the best biomarkers to assess who's going to respond to these.
Yep. All right, and one more question online. This is from Rhonda. Do pathologists know what to do with this?
Yeah.
So I guess the answer is going to be depends, but I don't know if you want to give your thoughts, or maybe if you're not sure if your pathologist does what you're requesting from your pathologist.
Yeah, it's important to have that good relationship if you can, or to sort of trust the pathologist that you're working with. And some of us are fortunate to have in-house pathology. Other times it's send out. And I think here it's important to, as much as possible, to kind of communicate what you're looking for, because sometimes pathologists kind of reflex to do certain tests if they think it's breast cancer or if they think it's lung cancer. So I have seen reports come back where they might do 4 different PD-L1 assay stains on a cancer, or they might do a HER2 stain because maybe the requisition said adenocarcinoma and it was a woman and it wasn't clear if it was breast or lung or So I think the more that you can sort of communicate what the clinical context is, the better. Sometimes there's a lung cancer that's metastasized to the brain or to the liver or and sometimes it gets on the requisition coded as brain cancer or liver cancer. So I think the more that you can sort of work and specify with pathology, or if you get a report back where it doesn't seem quite right, I think good to iterate a bit and sort of.
I'll say an issue we have when we have pathologists sometimes that are very exuberant about running immunohistochemistries of different assays. So we always write at the top of the report, NGS first, everything else later.
Right.
You make sure you've got the NGS. So.
Right. Yeah. Unfortunately, there's various like reimbursement considerations as to like how many times you do IHC or sequencing. So I think it's good to offer some guidance there.
Okay.
So
all right.
all right. Now we'll talk about some treatment options, and just to set the frame before I turn it over to Dr. Haimak here. Of course, we know there's a number of treatment classes or categories for various cancers, and in lung cancer, we've been fortunate over the last several years to develop more and more specific and targeted therapies. Of course, all the way on the left, there's still a very important role for cytotoxic chemotherapy with or without immune checkpoint inhibitors. But what we'll focus on a bit more today is some of the more novel targeted therapy options for HER2 mutant lung cancer with a number of recent approvals, thankfully, with HER2 tyrosine kinase inhibitors, including approvals in the first-line setting, as well as approvals of antibody-drug conjugates as well. So we will review the data on efficacy of chemoimmunotherapy for the HER2 mutant population, as well as data on kinase inhibitors, as well as ADCs here. So I'll turn it over to Dr. Haimak to...
Okay. All right, so here we'll jump into sort of first-line treatment options here. Now, this isn't the order that these drugs were approved in, but I think it makes sense to start with first-line treatment. And again, as Mark mentioned, we have options of chemoimmunotherapy and then targeted agents that are approved. So to start off with chemo and immunotherapy, I'll maybe harken back to something that Mark had raised. HER2 mutant tumors are like EGFR mutant tumors in the sense that they often happen in non-smokers, patients with low tumor mutation burden. It's often low PD-L1. So we think of these typically as relatively immunologically cold tumors. So, idea of some of the efficacy that's seen, platinum chemotherapy in this setting, response rates on the order of 30 to 35%. PFS on the order of 6 months. Chemotherapy plus immunotherapy, not a lot different. We have a couple small studies. One of them showed a little bit longer PFS, about 8 months. One thing we do know is immunotherapy by itself is typically pretty ineffective. We had taken a look at one set there, and PFS was under 3 months for immunotherapy by itself. So I think the take home for HER2 mutants is they typically do not really respond well to PD-1 inhibitors, and chemotherapy is modestly effective. Okay, so what are the mechanisms for the available HER2 drugs? So we really have two different types to focus on, HER2 ADCs and TKIs. Among TKIs, we have a few different variations. So just to remind everybody now, the FDA-approved treatment for HER2 mutant tumors, the ADC that's approved is T-DXd. It's otherwise known as trastuzumab deruxtecan. And to remind everybody about the mechanism, and many of you may also be familiar with this from breast cancer and other tumor types, it's an antibody with the payload. The antibody binds to the extracellular domain of HER2, and that's important, a region called domain 4. It gets taken inside the cell, endocytosed. The payload dissociates, and the payload induces a cytotoxic death. The payload can also be cell permeable and hit other cells. We call it the bystander effect there as well. And this is active in both HER2 mutants, and that includes those with activating mutations, but also the non-TKD mutations, again, the transmembrane or the extracellular mutations as well. Okay, now a second class of drug are these tyrosine kinase inhibitors. And to remind everybody, these drugs work on the inside of the cell. So they're small molecules, they penetrate the cell membrane, and they inhibit the kinase domain of HER2. Now the challenge here is HER2 and EGFR have very similar kinases. So it's a challenge to inhibit the HER2 kinase without inhibiting the EGFR kinase. So the early inhibitors in this space really were the ones that were originally developed for EGFR and also happened to work in HER2. So they were not specific for HER2 mutations. This includes drugs like afatinib as well. And so this blocks downstream signaling but doesn't affect what happens on the outside there. This illustrates the payload. Now I know this is a complicated slide to look at. This is what we call a ribbon diagram looking at the crystal structure of the HER2 kinase domain. And normally TKIs fit in between those different ribbons. Those different ribbons are alpha helices that are part of the, that surround the binding pocket. So when you see that TKI, that's normally where the drugs would fit in. And I think the point between HER2 and EGFR is they're really similar. In fact, there's only a couple of amino acids difference in that pocket. And so that's why it's hard to inhibit one well without the other. Now, HER2 kinase is actually a little bit bigger, so you can make a little bit bigger molecule that sort of fits in the back pocket, and that can help distinguish it. Now, why is this important? Because if you inhibit wild-type EGFR, you get the EGFR toxicities, rash, diarrhea, paronychia, right at the top, and that's really going to limit your ability to inhibit HER2 effectively if you've got to deal with that. Now, there's a new class of kinase inhibitors, and these are ones that are really designed to specifically inhibit HER2, but not EGFR. All right, so these are the HER2-specific EGFR-sparing inhibitors. And you see here zongertinib is really the first one. We've got some other drugs we'll discuss later that fit in the category, the Nuvalent 330 and the Iambic 1363. So these are selective for the mutant HER2, spare wild-type EGFR. That should minimize the EGFR-related toxicities. One other point about these drugs, these are covalent inhibitors, or zongertinib is, meaning it covalently links to a part of the HER2 kinase pocket, residue at what's called 805 there. That's important because that distinguishes some of the other kinases we have. Now, we have two kinases approved in this setting. We have zongertinib and we have cevabertinib. So just here to compare and contrast these two drugs. So both of them can inhibit the HER2 kinase, and they both are active against HER2 exon 20 insertions. Cevabertinib is also active against EGFR. In fact, it was originally tested as an EGFR exon 20 inhibitor. So it's a little bit broader, and that means it has additional activities, but it also means it carries some of that EGFR toxicity. Zongertinib is covalent, so it covalently links at that 805 residue. Cevabertinib is reversible, so it binds in and out. And right now, zongertinib is approved both for the first-line setting, and we'll go through some more of that data, and the second line. Right now, cevabertinib is only approved in the second-line setting. Okay, so here's a question, again, scan if you can. Based on the mechanism of action, why are HER2-selective TKIs being explored versus the pan-HER TKIs? So one possibility, greater efficacy due to higher intracellular concentrations, greater efficacy due to inhibition of HER2 homodimerization, reduced EGFR-related toxicities such as the GI toxicities like diarrhea, or reduced HER3-related toxicities like cardiac tox. So why don't you go ahead now and select the best answer. Okay, great. Well, here are the answers, and Mark, what's your thought on this one?
Yeah, I think where we've really made advances, and Dr. Haymock here has been key to advancing this field is developing more selective inhibitors. This is true across lung cancer and targeted therapy, but the more that we can selectively inhibit HER2 while sparing inhibition of EGFR in particular, that's where we've seen really substantial improvements in tolerability and being able to see high enough doses in clinic where we're now seeing impressive response rates. So I agree with the group here.
I agree here too. I think the others are things that sort of can make sense, but really the name of the game here for these inhibitors is reducing those EGFR toxicities. All right, and you can continue to submit questions here as we go along. And so here we'll talk about what the data is showing us for this next generation of TKIs, and we'll focus on the first-line setting for the HER2 TKIs. So right now we've got one TKI that is approved for the first-line setting, and this is zongertinib. So this is based on the BEAMIAN Lung 1, and if you're looking, it's cohort 2 there. So these are patients who are treatment naive. So this was a single-arm cohort. It was 74 patients in the main one. You know, the drug had earlier been tested at 2 different doses, but at the end they settled on 120 as the primary dose. And you can see here the overall objective response rate, 76%, median duration of response, 15 months, and the median progression-free survival, 14.4 months. Now, you know, I can tell you this is a huge step up from the earlier drugs we looked at. We had studied some pan-HER inhibitors earlier, drugs like poziotinib, where we had response rates in the order of 28 to 30%, PFS on the order of 6 or 7 months. So, you know, really a marked step forward in terms of this efficacy. Now, the second drug, cevabertinib, again, recall a HER2 and EGFR inhibitor, also a very high response rate at 71%, duration of response 11 months, and they haven't yet reported the progression-free survival, but you can see it's you know, in that area of a year there, so also a clearly active drug. And the FDA has granted breakthrough status for cevabertinib in the first-line setting. So we may have 2 options there, but right now, zongertinib is the one that is approved. All right, so that's the first-line setting. So that's the only targeted drug we have for patients who have not received prior therapies. But again, chemotherapy or chemoimmunotherapy remains standard options, not just for HER2 mutant, but other tumor types as well. So let me turn it over to Mark now to talk about later lines of therapy.
And John, I was going to ask you also, you know, before we wrap up the first-line data, you know, we talked about zongertinib and cevabertinib, but not TDXD in the first line. So what do we know about antibody-drug conjugates in the first-line setting, or what are we waiting to see?
Yeah, no, it's a great question because, again, we have a longer experience with TDXD. It's been approved for a longer time in the second-line setting. You know, we do have a big first-line study that's going to read out in the near future called Destiny Lung 4. That's a comparison of TDXD versus chemoimmunotherapy in the first-line setting, and we're eager to see where that comes in. You know, we know in the second-line setting, the median PFS was 10 months, you know, and we'll talk about that data a little bit more. So one would predict that it's going to be longer than 10 months when that data comes in. So, so obviously having more options is a good thing for patients here.
Right. So we've talked about the activity in the first-line setting, and of course, as Dr. Haymack mentioned, most of what we learned initially was in later lines before these drugs were tested in the first-line setting. And so here we see the BEAMIAN Lung 1 cohort 1, which is activity of zongertinib in previously treated HER2 mutant lung cancer. And again, this is focused just on patients with HER2 kinase domain mutations. And you see, again, a similarly impressive response rate of about 71%. So comparable to the response that we see in the first-line setting, and a median PFS of 12.4 months. So these numbers are, you know, just a little bit lower than what we were seeing in the first-line setting. And there's always that thought that targeted therapies may work even, you know, better when moved earlier on in a patient's disease course. So we have the approval of zongertinib now, also for first-line use in non-small cell lung cancer as well. What I think was also very important, we know that brain metastases are a big problem in lung cancer in general, and also for patients with HER2 mutant lung cancer. And the BEAMIAN Lung 1 cohort number 4 looked at patients with active untreated brain metastases. So these are ones that weren't treated with radiation therapy prior to receiving zongertinib. And you can see here they're looking at the intracranial response rate, which again you're seeing in most of these cases, tumor shrinkage often very deep. And the median duration of intracranial response you can see here was about 6.9 months, with a median intracranial PFS of 8.2 months. So we see good intracranial efficacy with zongertinib. This is a relatively small population, but important as we see more and more data from targeted therapies. I think it really behooves us and in drug development to have these dedicated CNS cohorts so that we really have a better sense of how well these drugs work, not only systemically but in the brain as well. Now we have data from SOHO-01 cohort D. This is cevabertinib, again in previously treated HER2 mutant lung cancer. And this is about 81 patients with HER2 mutations, a response rate of 64% and a median PFS of about 8.3 months. So cevabertinib currently is approved for HER2 mutant lung cancer, specifically in this population, the previously treated setting here. So whether these numbers are substantially different, John, like the response rate, the PFS between cevabertinib and zongertinib, do you feel like you can compare across these trials in the second line or first line settings?
First thing I have to say is they're both clearly active drugs, and that's a big win. I think it's important to have a perspective that, until these two drugs came along, the TKIs we were using had response rates in the 20s and 30s, again, pyrotinib, poziotinib, neratinib was lower than that. We had a lot of drugs that were that were in that. So both of them are leaps and bounds beyond the drugs we had before. I think overall the efficacy and tolerability, I think are a little bit better in zongertinib, but they're also mechanistically different, and I think that may give some opportunities for sequencing. So they're they do a little bit different things, and I think there'll be advantages to having drugs that are a little bit different.
Right.
Yeah.
And here from DESTINY-Lung2, we see activity of the HER2 ADC trastuzumab deruxtecan, which is also approved in indications outside of lung cancer, of course, breast and gastric cancers as well, with HER2 aberrations. But here, this was focused on non-small cell lung cancer with HER2 mutations, and this study was slightly different in that it also not only included the HER2 tyrosine kinase domain mutations, but did allow other HER2 mutations, as you can see indicated above the waterfall plot. There were some patients with extracellular domain mutations, and I think some with transmembrane domain mutations as well. And here you see a response rate of 49%, median duration of response about 16.8 months, and a median PFS of 9.9 months here. So, good waterfall plot, lots of tumor shrinkage here. And so currently trastuzumab deruxtecan is FDA approved in previously treated HER2 mutant lung cancer as well. It also inclusive of HER2 mutations outside of the kinase domain that are activating here. So with these different agents available, and some trials have allowed patients to receive one class of HER2 targeted therapy in order and still allow them to receive the others. Other trials say if you've had a prior TKI, you're not allowed to go on to another HER2 TKI study. So, but we are starting to see some emerging data sets in patients who have received different prior HER2 targeted therapies and then go on to TKIs or other treatments to have a sense of the activity after sequential HER2 targeting strategies here. And that's summarized here in this slide. So the top row shows the activity of zongertinib on the left, cevabertinib in the middle, and trastuzumab deruxtecan on the right in patients who received prior systemic therapy, the platinum-based therapy with or without immunotherapy. And so here you can see the response rates of 71%, 64, 49%, and you see the median PFS on the top row, 12, 8, and 9 months. On the bottom row is in patients who have received prior HER2 ADCs. So this is trastuzumab deruxtecan by and large, who then go on to receive treatment on trial with zongertinib or cevabertinib. And you do see a step down or a drop off in the response rate and in the PFS compared to the efficacy after non-HER2 targeted therapy. And John, a really important question, in lung cancer in general, but for HER2 specifically, are mechanisms of resistance. And, we do have, some understanding. I think we're just starting to scratch the surface of mechanisms of resistance to antibody-drug conjugates. There have been studies, out of breast cancer, mainly, patients going from TDM1 to TDXD. We don't have as much data in lung cancer necessarily switching ADCs at this point, but what do you make of this? Why do you think there's a step down in efficacy with the TKIs after prior TDXD?
Yeah, it's a good question. I mean, as you said, we're just touching the surface. This is an area where I think we're going to learn a lot more over the next year. The TKIs and the TDXD are different, and we think they have different mechanisms of resistance, or most of the mechanisms are different. We've seen a little bit with TDXD that it looks like it's largely payload resistant to that deruxtecan payload. And you remember that this is a TOP1 inhibitor, so at least the mechanisms we've seen in preclinical models and some clinical data are things that make you resistant to the payload, Schleffer-11 loss or topoisomerase mutations or loss and so forth. Whereas the things that make you zongertinib resistant, that we know at least so far, include alterations at that 805 amino acid that I mentioned before. So you might say, well, if they have completely different mechanisms of resistance, the sequence shouldn't matter that much, but it clearly matters somewhat. The activity is clearly lower after HER2 therapy. After a TDXD, zongertinib and cevabertinib clearly have a drop-off in activity. So I think we have more to learn because they must share some mechanisms in addition to having these separate mechanisms of resistance.
So
Okay.
now we'll switch it back over to John to talk
Yeah,
about
so I'll talk about so what are our current standards of care then? So we've gone through now first line, second line data here as well. So just to sort of summarize this right now, we've got the three drugs in the space, zongertinib, cevabertinib, TDXD. For activating mutations, now it's a little bit of a loaded term, but if we think of the tyrosine kinase domain mutations, which are the sort of the classic activating ones, zongertinib is approved and cevabertinib is approved. If you take any activating mutation, including the extracellular ones like that 310 and the transmembrane, TDXD is approved for the non-TKD mutations as well. Zongertinib is oral once daily, cevabertinib is twice daily, TDXD is intravenous once every 3 weeks. And right now, all of them are approved in the second line setting. Zongertinib has an accelerated approval for the first line setting. So that's the difference. The other things we'll point out, cevabertinib is a non-covalent inhibitor, zongertinib is a covalent inhibitor. That carries pluses and minuses as well. So what are the guidelines? So this is the most recent NCCN guidelines that were recently updated for metastatic HER2 mutant. So one choice, and I think it would likely be the first choice of most people, now that give these drugs, is zongertinib. And at the time of progression, you have a couple choices. You have chemotherapy. Now remember, TDXD and cevabertinib were approved after chemotherapy. So if you got chemotherapy, then you could go on to TDXD and perhaps consider cevabertinib, although that wasn't a recommendation. Or you could start with immunotherapy and chemotherapy. And if you start with immunotherapy and chemotherapy, then you could pick any of the three drugs approved in the second line setting, zongertinib, cevabertinib, or TDXD, and then switch to the other. So this is the current recommendations, but obviously we're going to learn a lot more as time goes on in the near future. So here's an open question. Given what we've seen so far, would you use cevabertinib after first-line zongertinib or vice versa? So Mark, your thoughts on this?
Yeah, it's an interesting and important question. We didn't necessarily see that on the last slide with the flow diagram of sequencing these TKIs one after the other, and we try to borrow from other mutational paradigms in lung cancer. We have a history of switching from one TKI to another. For example, in the early days EGFR when we had, erlotinib first, and we looked for the T790M resistance mutation, switched to osimertinib, you could still see good activity in that specific population. Or, for example, in the ALK setting, you can see activity of lorlatinib after treatment with other prior ALK inhibitors in many cases. Here, I think it's an unknown, especially as drug development is getting more and more advanced, before drugs get into the clinic, where these drugs are quite potent and selective, and we don't necessarily know as much about if one has better CNS penetration than the others. So theoretically, if a drug does not have a lot of CNS activity and you see CNS progression and you switch to another drug with better CNS activity, that you can sometimes rescue CNS progression. I think, as John said, we're learning about mechanisms of acquired resistance to these TKIs, and there's preclinical data and emerging clinical data sets to be able to start to answer this question about whether TKI can overcome resistance to the prior one. There are likely many cases and mechanisms where resistance to one TKI confers resistance to others, but there may be specific on-target resistance mutations that may have differential sensitivity of one versus the other in the covalent binding site, for example. But this is something that I think if a patient, for example, had first-line zongertinib and progressed, I don't necessarily think my second choice would be cevabertinib. I'd probably choose other therapies, either TDXD or chemoimmunotherapy, depending on various considerations. Maybe at some point I might, try to go back to another HER2 TKI on trial, but I don't know, John, what are your thoughts?
Yeah, I'd agree with that. I would probably make one or two exceptions. From the world of EGFR, if those you remember the T790M as one mechanism and the C797S for osimertinib, here the analogous mutation to C797S is the C805 for zongertinib. So if somebody had a C805, I would be very comfortable switching to cevabertinib. And we've actually had a couple cases now of cevabertinib responders after zongertinib. So it won't be for everybody, but I think there will be cases where this makes the most sense. So, I guess we'll have a quick question here, and then we'll move on to the last sections here.
Right, so here is a patient with treatment-naive, non-squamous metastatic non-small cell lung cancer harboring a HER2-TKD mutation with active brain metastases. And based on the current NCCN guidelines and available clinical evidence, which of the following HER2-targeted therapies would you prioritize as first-line treatment for this patient? Trastuzumab deruxtecan, zongertinib, cevabertinib, or trastuzumab emtansine, which is TDM1. Great. So the majority said zongertinib, which I think I would choose if I had a patient in clinic next week with a HER2 mutation and metastatic lung cancer. So I agree there. All right. So we will, in the last few minutes, go on to discuss some of the safety profile considerations of these therapies.
Yep. Okay, great. Well, thanks. So again, we spoke before about how inhibition of wild-type EGFR is what causes a lot of the toxicities here. So again, the GI tox, diarrhea, and rash really are classic EGFR-related toxicities. So for zongertinib, we saw 52% had diarrhea, 32% had rash, but that was essentially all grade 1, 2. In terms of grade 3 or 4 GI tox or rash, it was only 1%. In fact, I think there was only one patient who had a grade 3 acneiform rash. And then others, also grade 1, 2, fatigue, musculoskeletal pain, and so forth. Okay, so in terms of ILD, only in 1%. And I think that's relevant because we know there was a significant ILD signal with trastuzumab deruxtecan. And that really prompted clinical studies at the lower dose. If we look at the percentage that had dose reductions, it was 7%, dose interruptions, 28%, but only 3% had to discontinue. So overall, I think this is a very manageable safety profile, and there were some patients who had LVEF decrease, so I think it's important to continue to get echocardiograms. All right, now cevabertinib, again, a manageable drug. We do see higher rates of grade 3 or higher diarrhea. So 87% with diarrhea, 18% grade 3 as compared to the 1%, 1.5% with stomatitis, and grade 3 rash in 1.5%. So heavier on the GI tox, but lighter on the rash, and a lot of paronychia there as well. So going along with it, having a little more EGFR inhibition. Good news, no ILD signal, no LVEF. There were 6% who had cardiac arrhythmias, so I think following this is important as well. And about 46% had dose reductions, but 4% dose discontinuation. So I think that says it requires active management. It requires knowledge of how to manage the GI toxicity in particular and the rash. But if that's done, discontinuation rate is relatively low. All right, so Mark, why don't you talk about the antibody-drug conjugate then?
Yeah, so I think here we are seeing a different side effect profile of the ADC compared to the TKIs here. So this table, importantly, is adverse events with an incidence of at least 20%, but we'll talk about on the next slide other important side effects of antibody-drug conjugates in this population here. So here you see generally, there are some lower grade GI toxicities, but relatively lower incidence of high-grade GI toxicity or drops in appetite. Given that this has a cytotoxic payload, here we see more of the hematologic abnormalities with neutropenia, anemia, leukopenia, thrombocytopenia, et cetera. There is some lower grade alopecia with the ADCs, and then some transaminase elevation, again, tends to be a lower grade, but a very important side effect to be mindful of with trastuzumab deruxtecan, as shown here, is interstitial lung disease or pneumonitis. In our lung cancer population, the incidence was about 13%, and this has been seen with this drug in other tumor types as well, with various incidents in breast and gastric cancers as well. And there can be, this can be quite serious, so it's important to recognize early. About 18% of patients needed dose reduction, 45 interruption, about 15% needed treatment discontinuation for side effects here. So this is a unique side effect. Of course, TKIs rarely can cause pneumonitis as well as a class of medication, so it can happen with all of our systemic therapies, but here it is a higher incidence.
And you can see the discontinuation rates compared to the TKIs. TKIs were 3 or 4, here it's 15, so it's, it requires active management, obviously.
Yep. And so we'll go to this question here. Which of the following statements is true regarding the class toxicities observed with cevabertinib and zongertinib in patients with HER2-mutant lung cancer? The first option, any grade nausea was more common with cevabertinib than zongertinib. Any grade paronychia was more common with zongertinib than cevabertinib. Grade 3 or above diarrhea was more common with cevabertinib than zongertinib, or grade 3 or above rash was more common with zongertinib than cevabertinib.
All right. You're digging into the details on this one, so this...
So grade 3 diarrhea more common with cevabertinib, but with all of these, you can see diarrhea, you can see rash, paronychia, nausea, et cetera. So again, and we don't exactly have a sense of why certain patients get the side effects that they do. So important to be aware of all of these side effects across these agents here. So.
And I think my experience with that is pretty consistent here as well. Yes. So I think the diarrhea requires management. And I think if you look at the SOHO study, patients did better and better over time. That probably means that the management got better, over time with the diarrhea. So. All right. So finally, how do we select patients here? For TKIs versus chemoimmunotherapy in the first-line setting here. So, Mark?
Yeah, so this table kind of summarizes some of the differences across these agents, given that they have approvals in the second-line setting and zongertinib in the first-line setting. So again, there's a slight distinction in the FDA label with zongertinib and cevabertinib just being approved for HER2 mutations in the kinase domain, whereas TDXD is a little bit more broad. But again, the majority of the mutations that we see in HER2 are in this tyrosine kinase domain. You see different routes of administration, so some patients prefer oral therapy once a day or versus intravenous therapy. We are seeing more and more data on activity in patients with active brain metastases. Given that these drugs hit HER2 or inhibit HER2, there are important considerations in terms of potential cardiac toxicity, and this is an area that we don't know much about because a lot of patients with a low ejection fraction were excluded from participation in these trials. So again, the HER2 mutant lung cancer population on average tends to be a younger, healthier, never smoker population, but there are older patients or patients with CHF or other comorbidities where you do worry about the potential added toxicity, cardiotoxicity with any of these HER2 targeted therapies. Again, there is a risk when patients have prior or pre-existing interstitial lung disease for any of these agents. So those are patients that were excluded from participating in the trial, so we don't have a lot of clinical trial data at all in this population. You see some differences in diarrhea, the ILD, and then some of the cardiotoxicities here. So I think, when you're seeing a patient together in clinic, John, are there any factors that might make you choose, like not start with HER2 targeted therapy and use, chemo or chemoimmunotherapy?
Yeah, I mean, I think, in terms of things for me, I think for a patient who comes in with good performance status and no particular comorbidities, I think if they haven't gotten zongertinib in the first line, I think I would, be leaning zongertinib now. That's what we certainly have the most experience with. I think, if ejection fraction is an issue, I think that would be a consideration, there that it would be worth taking into account. It's, I think if somebody's got brain mets, the fact we've got established data in the first line setting, at least with zongertinib and in the second line, there is some data for TDXD, and it does have some activity against brain mets as well. I think with TDXD, they excluded patients with a lot of different pulmonary conditions, COPD, pulmonary embolism, pleural effusions, and so forth. And given the ILD, I think with pre-existing pulmonary conditions that are concerning, I think that would strongly push me away from TDXD. So I think overall, I think zongertinib would usually be what I would lean towards, but those would be some considerations for other things there. So, all right, and I think I think this is our last question. So, a patient with advanced non-squamous harboring a HER2 TKD mutation presents with disease progression after first-line immunotherapy. For the sake of the question, let's call it chemoimmunotherapy, if we're going to stick with the label. Moderate COPD with reduced baseline pulmonary function. Based on NCCN guidelines and the clinical evidence, which of the following therapies would be prioritized? So somebody who started with chemoimmunotherapy, let's say, what are they going to get second line with the TKD mutation? So HER2-targeted ADC, HER2-targeted TKI, chemoimmunotherapy, or chemo plus ramucirumab here. All right, so why don't you go ahead and answer it? Okay, so answers have come in. It looks like HER2 TKI is the top choice. Mark, what are your thoughts here?
Yeah, I would agree. Based on available data in terms of response rate, PFS, we think TKIs show better efficacy. And again, when patients have baseline lung abnormalities, you worry a little bit about adding ILD potential toxicity. So it gives me a little bit pause before going to an ADC. But at some point, with any of these comorbidities, it's all about competing risks. So if patients progress in you need to switch to another systemic therapy. You have to kind of figure out, is the cancer more of a threat to the patient or COPD? So.
Yep. Good. Okay. Well, I think I'm agreeing with our audience for virtually all these. We're going to go a little bit quickly here through the last section in the interest of time, get everybody out in it with the rest of their evening here. So, Mark, you want to talk about managing ILD related to TKIs?
Yeah. So, this is one of the feared side effects of any of our systemic therapies in lung cancer, ILD, because it can become quite serious and symptomatic, and patients can be hospitalized. So this is something you have to watch carefully. And there are slight differences in the FDA, package insert and guidelines in terms of how these are managed. So grade 1 usually just means radiographic findings alone, but no symptoms. And in this setting, zangertinib has been continued on the trials and at the same dose, whereas on the cevabertinib studies, they were a bit more cautious and recommended permanent discontinuation of any grade of ILD. As the grade goes up for zangertinib, with grade 2, where patients are starting to have some symptoms, this is where you want to potentially get a pulmonology consult, hold the dose until the ILD resolves. You could resume potentially at a lower dose and consider other alternative supportive measures, and then if ILD comes back again, that's another strike and you're out. So I think you would stop at that point. Grade 3 or above is obviously more severe, requiring a lot of oxygen support and hospitalization. We would permanently discontinue. And I think also for HER2 targeted therapies in general, we do want to be mindful of potential long-term cardiac toxicities here. So there are some different guidelines in terms of LV-EF monitoring for zangertinib, but not cevabertinib. Whether that's, there's a real distinction there, it's not as clear to me in terms of cardiac monitoring and side effects if, one study was just, again, a bit more conservative than the other. But again, we usually try to get a baseline echo at some point before starting HER2 targeted therapies, and then monitor at some regular interval, and then shown here, depending on the change in LV-EF from baseline, again, you might want to hold the dose or permanently discontinue, especially when symptoms start to arise here. And then lastly, the diarrhea management is important, and it's important to counsel patients at the outset that they may experience this or that it may be frequent, so to encourage early and frequent use of antidiarrheal medications like loperamide, and to counsel patients how often they can take it, make sure they stay up on hydration and fluid losses, and see if there are any food triggers or patterns to their bowel symptoms. So.
And I'll say with zangertinib at least, I've never had to go beyond loperamide, and I've had to do that just in a minority there as well. All right, let me briefly touch on the confirmatory studies here that are going on. So for BEAMI Lung 2, this is the confirmatory first-line study, zangertinib versus standard of care, which is chemotherapy with immunotherapy. Primary endpoint of this study is PFS. This is a study that is very well along. SOHO 2 is a similar design, except instead of zangertinib, it's cevabertinib. Again, first-line HER2 TKD mutations, cevabertinib twice daily versus standard of care chemo immunotherapy there. So two similar studies going. And we don't show it here, but we have the Destiny Lung 4, which is the same design except with TDXD. So we'll have first-line studies with all three drugs that read out in the foreseeable future. All right. So in less interest, we'll just spend a minute talking about other TKIs, and we'll get to the key take-homes.
A few new drugs on the horizon being tested in earlier phase clinical trials now. There's NVL-330 from Nuvalent, again, looking at this similar population, but also allowing prior treatment with HER2 antibodies and ADCs. There's the iambic drug IM1363, again, being tested in this population, and now we're seeing some preliminary data on efficacy, so this is something to keep an eye out for. There's always questions about other combinations.
Yep.
Should we be combining the available or approved TKIs with chemotherapy? Should we be combining them with ADCs? I think we'll look forward to seeing those data sets as they emerge in the coming years.
So these are two drugs I'm sort of excited to see here. So All right, finally, why don't you take us home with key takeaways, and then we'll see if there's any questions.
I think this has been an exciting time, and thank you for your engagement. We'll have some time for a couple questions as well, but I think we're certainly seeing that HER2 targeting TKIs are an effective oral treatment for HER2 mutant lung cancer with predictable toxicities, but manageable, I think, side effects as compared to some of the available HER2 targeted ADCs and pan-HER TKIs. So zongertinib is HER2 selective, approved in the first-line setting and beyond. Sivabertinib as well, approved in the second-line setting and beyond. And then trastuzumab deruxtecan, not a TKI, but ADC, approved in the second-line setting and beyond. So a lot of good treatment options. Yep. Upfront biomarker testing, of course, is super important, and these ongoing confirmatory phase 3 trials are underway. So we'll look forward to those results, yep. And we'll have a few minutes for questions.
I agree with all that. You think about where we were just a year or two ago, and it's a whole different world here. So it's wonderful to see HER2, finally yielding here to some extent. Okay, we will open it up for questions. Any from the audience? So,
and I have one here. Oh, yeah, sorry.
Up, Daniel? Yeah.
Yeah, so John, I might also like add to that question, Daniel. Yeah. Thank you. If you have a patient, say with PD-L1 of 95%, we know like for ALK that doesn't necessarily mean immunotherapy will work, and you should still use the ALK TKI. Do we think that's true for HER2? Should we use chemoimmunotherapy or just chemo alone for HER2? And is there any concern or risk if you start with chemoimmunotherapy and then switch to a TKI? Coming off immunotherapy, are the toxicities higher potentially? Yeah. So a few questions.
Yeah, we don't have answers to all those, but what we can say is the following. We don't have a comparison of chemo versus chemoimmunotherapy in this group, but ICI by itself does just about nothing. Now, we don't have big enough cohorts like we do for EGFR or ALK to say, well, what about the rare ones that have 95% PD-L1? But that very, very, very rarely happens there. I think probably there's not a big difference between chemo and chemoimmunotherapy. Immunotherapy probably doesn't add much. I might be more likely to add immunotherapy if the PD-L1 is really high. With the zongertinib studies, we didn't see pneumonitis at all, and most of those patients had immunotherapy before. So I don't think there's the way with osimertinib, where we do have a big signal in pneumonitis after immunotherapy. We're not seeing that with zongertinib. And I don't believe with sivabertinib either. Again, 1% pneumonitis. So I think these TKIs can be given after immunotherapy, but immunotherapy is probably not doing a lot for these patients. So, but great question there.
Thank you. I'm sorry we won't get to all the questions today, so we'll wrap up, but we can stay if there's more questions from the audience. But all right. I wanted to thank everyone for your participation and attention, and you're welcome to download slides with this QR code, and there'll also be a multimedia version of this symposium online in the coming weeks. So thank you so much. You can follow Answers in CME on LinkedIn or visit answersincme.com for more information. So thank you so much.
Thank you.
Thank you for listening. Please visit the activity URL in the episode description to view all program materials, complete the post-test, and get a certificate.